of organizing committee, I welcome Dr. Kiran Makhija sir. He is a senior consultant pediatrician and director Makhija Children Hospital, Raipur. Sir, the stage is all yours.
Okay, thank you, Chairperson, sir, and thank you, the organizing committee, for inviting me here to deliver the talk on the latest in iron chelation therapy. So, what you expect the latest? But I want to know what older you are knowing. What is the meaning of latest? Everything which we don't know, it is latest. So previously, the two drugs used to discuss among the iron chelation therapy for the chronic anemias, for chronic hemolytic anemias, where we used to give the blood transfusion therapy for lifelong. So there will be the iron overload and treatment has to be chelation of the iron. So coming directly to the topic, so how the iron overload occurs? The first step is by the anemia. So lifelong blood transfusion has to be given. So this will increase the iron content of the body about 4 to 5 grams in the body yearly. And the second mechanism is the dyserythropoiesis occurs here. Therefore, there will be the decreased hepcidin production and there will be the increased GI absorption. So this both process leads to the iron overload in the body. And this iron is actually dangerous. Why? Because it is not naturally excreted from the body. It is the transferrin bond. The iron which is absorbed or is there in the blood is the first, it is usually the transferrin bond. And after the 33% of the bondation, the process is like that there will be the liberation of iron in the non-transferrin binding iron form. So it is in short NTBI or labile iron. And this labile iron is highly dangerous. How? It causes the release of the free radical by the Fenton reaction and it leads to the lipid peroxidation, cell damage, organ damage and the fibrosis. So the whole process causes the damage in the body. No excretion, therefore the uncontrolled iron deposition in various organs. So reversible manifestations are there. Initially, in the heart, it will be only the cardiomyopathy, the conduction disturbances that can be reversed. In liver, it will be the abdominal pain and hepatomegaly that can also be reversed. In skin, the pigmentation may occur, so that can also be the reversed. But what happens? You may know me, that is the reversible things, but you don't know what are the irreversible things. But you have no idea who I am. So these are the complicating things. In the first decade of life, it is the reversible process. So the irreversible process, what happens? Mainly the endocrinal organ, heart, liver and the joint. And it causes the arthropathy in the joint, the permanent damage after the first decade of life. And heart, it is the main cause of the mortality in the person who is having the blood transfusion for lifelong. So this is a beautiful slide you can see in the pre-symptomatic phase. In the first decade of life, the iron level is not so much and this is reversible processes, so asymptomatic. To maintain the hemoglobin level of the 10 around before the transfusion. So these are the things which are leading to the complications in the second decade of life. And the main cause of the mortality is the cardiac failure. So chelation process, what is the process? This is the non-toxic drug which is causing the toxic thing in the blood is there, that has to be combined and excreted, which does not causes any complication in the body. So this is the chelation process. So usually iron chelation has to be started if the patient who is infant receiving the blood transfusion after 6 months of the life, he has to receive the chelation therapy usually after the 15 to 20 blood transfusions, and you can say that after 1 or 1.5 years you have to start the iron chelation therapy. So iron is available, but the important thing is that always the iron available to the chelator is very limited. So irrespective of the total body iron, prolong and the higher dose is required when the levels are very high. Prolong means lifelong therapy is there, but the higher dose of the therapy you have to be kept for the longer period. And the heart which is the main cause of the mortality, it responds very slowly. There are three drugs. The first one is DFO, desferoxamine. This is the highly potent. Please remember, this is very highly potent, and this has to be given by the infusion pump. This is injectable therapy. Second one is the oral deferiprone. This is less potent. And the third one is the oral deferisirox, high potent. So this is the third newest drug which we have got in our therapies. So oral deferisirox was compared with this highly potent previous drug. This is DFO. So now the patient, they find the more compliance of the therapy with the oral therapy. So coming to the first drug, the free iron has got the 6 free sites that has to be combined with any drug for the chelation. If any drug having the polydentate or the hexadent, so this will combine the free iron very better, in the better manner. So that has to be taken care. This is the high potent drug. So this is the polydentate drug. This is DFO, the first one. This is high molecular weight and injectable form. This free iron has, this polydentate and the hexadent chelators, they bind more tightly with the free iron. This desferoxamine is available in the name of desferal. And this is the injectable therapy. You can see in this picture, this pump is there. It is combined to be the normal saline and has to be given throughout the day. Why? Because it has got the shorter half-life. So prolonged subcutaneous infusion is required. So patient asks, कितने देर तक देना है? So at least 12 hours, 14 hours, you can give the advice. Selective and the fast acting first line drug, dose is 20 to 40, and the oral vitamin C, this causes the oxidation process and leads to the deoxidation process, and before the infusion, this will help in the binding of the iron with the drug. So toxicity is there, local reaction, allergy, ocular and the auditory, and the growth plate arrest may occur. Limitations, you know that needle pump is there, so compliance is it is not good, it is the main issue. The high cost of therapy is there. This vial, 500 milligram, that cost around 200 rupees. So per day therapy, if 2 vials has to be given, 400 rupees he has to bear. So not a good iron chelator also. The main cause of the mortality is the heart problem. And the iron chelation, this is not a good iron chelator. So this, though it is high potent drug, but then also we are not getting advantage of the heart iron chelation. Yersinia infection, some patients we have seen. The second drug is the low potent, but it is very important drug. Zero का क्या value रहता है? You can say that zero का कोई value नहीं रहता. लेकिन जब किसी के साथ जुड़ता है तो that becomes the 10 times. So this is the drug which becomes 10 times. This is actually the bidentate molecule is there combining with the iron. So 3 molecule of the drug is required. Therefore, it is the low potent. It is very cheaper and best used when it is used in the combination. As I have said, children over 6 years only can be used. This drug cannot be used before 6 years. The main cause, the main problem is the adverse events like the agranulocytosis, which is not a dose dependent. And the second thing is the joint pain, arthralgia, erosive arthritis, dose dependent. These are the 2 important side effects practically we see in our practice. So we have to take carefully, like the hydroxyurea yesterday we have discussed. The agranulocytosis here occurs. So we have to monitor very properly. Patients have the urine red color. The third drug is which is the newest and the highly potent. This is actually tridentate, low molecular weight and oral form. So it was compared that now the chelation problem by the injection which we are facing in the compliance form by the first drug DFO, now it has been solved. So what we are practically seeing that after 10-12 years of this drug use, after that we are getting the some of the patients we are getting good results, but some of the patients we are not getting the results properly. And among the more than 700 tested compounds, it was selected. It is 5 times more efficient than the first drug in the liver only, not in the heart or in the other places. The dose is same, this 20 to 40 milligram, and iron is excreted in the feces. It is available with the various names in the market. This Desirox is there, Asunra is there, Defrijet. This drug is actually given not in the, it is not to be swallowed directly. It has to be dissolved in the water and the orange juices and the apple juices, and not to be swallowed and chewed. The side effects are insignificant. Long-term safety data, no, not available, but it is safer. So various these differences are there. The combination, important thing is that no one drug has got all the advantages. So we have to give in the combinations. Like the newer drug which we are using and the combination of the first drug, both highly potent in the form of the helps in improving the compliance, and the second one helps in reducing the iron from the heart. Combination of the previous two drugs, this first one DFO and the DFP, this intracellular and the cardiac iron, that can be reduced properly. So approach is there. When the age is less, you can start with this, the third one, Deferricirox, DFX, and after the 6th year, you can introduce the Calfer. When the iron level is very high, we see usually by the serum ferritin level, not the direct iron level. So serum ferritin level has to be tested 3 monthly. So we used to give all the 3 drugs in these type of the patients. So, but take care of when the drugs are increasing, toxicity you have to monitor. Chelation in the various conditions. The important thing is that the third drug, the newest one, that causes the increase in SGPT level. But mind it, if it is more than 5 times, then only you can stop that drug. Otherwise, you can very well begin with that. In kidney disease also. Otherwise, the previously both drugs where they are available, so you can use both drugs. Heart disease, combination of all the 3. Arthritis, don't use the first 2 drugs. Monitoring, it is very important in the point of the toxicity. The monthly CBC is there, and before blood transfusion, and the serum ferritin, LFT, RFT, height, weight, once in 3 months. Dental examination, cardiac function, viral markers, vision and auditory testing, because of the toxicity of the drugs. The important thing is the iron monitoring by the T2 cardiac MRI. This is to be done 6 monthly. And the endocrinal evaluation because of the iron overload. The bone metabolism you have to see, especially after 10 years of age. So the serum ferritin, it is easily, inexpensively available test and can be repeated, and positive correlation we have seen. But the important thing is that it has got the indirect value and it gets fluctuate in various conditions. The important thing is levels. Less than 1000 or 2000 you can consider it is the safer one. And more than 2500 it is the dangerous, and more than 7500 it is lethal. T2 MRI, it is the non-invasive, but 1 yearly testing is recommended. It costs around 6,000 rupees in the rebate. Not available in Raipur or Chhattisgarh. A patient has to send, we have to send to the Delhi or to Bangalore. Prognosis, partially treated. As you know, the toxicity is there. Second decade of life is dangerous. And if it is well managed, then patient can live up to the 5th decade of life. So we all have to die of something, but it should not be the iron overload. Conclusion is that advances in the iron chelation therapy and regimens helps in the maintaining iron at a safe level in the majority. Compliance with therapy is the strongest predictor of the success of the therapy. Focus should be made on the the individual needs, and has to be monitored carefully. Thank you very much.
Thank you so much, sir. It was a very fruitful session. I know that iron is one of the most commonest supplements that we use to provide in day-to-day practice. So this drug can be lethal as well. So every time when you use this drug, you should be aware of its complication as well. Um, so thank you, sir, for giving us such a nice lecture. If any one of you have any queries, they can ask now.
Otherwise, I will ask questions. So can anybody tell 6 महीने के बच्चे में क्या करना चाहिए? We have to start or not? Yes or no? No. 1 year? Usually after 15 to 20 blood transfusions, अगर 1 साल में हो गया तो you can start. और 3 साल के बच्चे में combination therapy, whether to give or not? The main thing is serum ferritin level. You have to see the serum ferritin level. अगर serum ferritin level within a range है less than 2500, so you don't start with the combination. The first drug, the newest drug you can start because oral therapy is good. So if the serum ferritin level it is more than 4000, you have to give the combination therapy, irrespective of the age. But Calfer cannot be given before 6 years of life. So you have to be very careful. Agranulocytosis is there or knee arthritis is there, don't give Calfer. Calfer is the second one, this DFP. You can easily remember the DF it is common, O, P and X. OP is in continuation and X is the last one, previous one. So OPX you can remember. वो अदरवाइज ऐसे भी याद कर सकते हैं पी DFP it is the also known as L drug. L drug means the L1 it was given to the name. So OLX can be easily remembered. Thank you very much.